Welcome to the Immunodeficiency Foundation's online course for nurses in primary immunodeficiency diseases and immunoglobulin therapy. This section is an overview of immunoglobulin therapy and the disease states for which it is utilized. I am Dr. Jordan Orange. The title of my presentation is the overview of immunoglobulin therapy and the disease states in which it is utilized. It is my great pleasure to speak with you today about this topic. In the way of objectives, there are several topics I would like to cover. The first is a general introduction to immunoglobulin therapy. The second, the immunoglobulin products themselves and the changes in the landscape. The third, some emerging treatment options with immunoglobulin therapy. And then I would like to move to primary immunodeficiency diseases themselves and the optimization of immunoglobulin therapy, some opportunities for the home infusion professional in particular, and finish with some ongoing research and future implications in therapy. So in the way of introduction, let's talk about what therapeutic polyclonal immunoglobulin actually is. As you see from the diagram in this slide, this is a space-filling model, magnified many, many times, of an antibody molecule. In particular, immunoglobulin G. Polyclonal immunoglobulin that's used therapeutically is highly purified IgG, immunoglobulin G. This is the major antibody present in human blood, and there are amazingly billions and billions of different specificities contained within the antibody molecules, the IgG molecules, circulating in our blood. The two red arrows point to the important regions of the molecule. The two regions that look fairly similar are the combining sites, the so-called antigen combining sites. These are where the billions and billions of specificities are contained. And every single antibody molecule can have a unique specificity. The singular region that's pointed to on the bottom of the slide, this is what is called the constant region. And in the IgG molecule, there are four major constant regions: IgG1, IgG2, IgG3, and IgG4, the so-called immunoglobulin G IgG subclasses. Antibodies, including IgG, are produced by B cells. These are lymphocytes of the immune system that serve as the factories for antibody. So the next question becomes, how does IgG work? And I'll cover that in the next two slides. It works in a variety of mechanisms to protect us from our environment, to keep us healthy. Most obviously, the IgG molecule specifically binds harmful substances, such as bacteria, viruses, or toxins, and it neutralizes them. It can also enable interaction with other parts of the immune system, other immune cells, to access function against that dangerous element. When it's interacting with immune cells through the constant region, it can bind to specific receptors contained on the immune cells. This allows the antibody molecule to access immune function and, importantly, also to regulate immune function. In the next slide, here are a series of examples of how antibody molecules can function in disease. And these are really divided here in this slide into two categories. The first are the anti-infective mechanisms, those which fight infection directly. These are things such as coating of the dangerous organism with antibody. That's a term in immunology we call opsonization, that can lead then to the neutralization of the pathogens. It can lead to fixation of something called complement on the surface of those organisms, which can lead to its direct destruction. And it can activate other parts of the immune system, such as the engulfment by immune cells, a process we call phagocytosis, and I'll demonstrate that for you in the next slide, as well as something called antibody-dependent cell-mediated cytotoxicity, where a cell of the immune system binds and destroys whatever the antibody is bound to. Now, all the way on the other side of the slide, we have immunomodulatory mechanisms. These are when the antibodies can control immune functions. For example, if one has antibodies that are dangerous in their own body, antibodies directed against themselves called autoantibodies, therapeutic immunoglobulin can dilute those out. It could also downregulate certain immune cell functions, and this has recently been described to occur through particular types of antibodies present in polyclonal immunoglobulin that have sialation residues contained on them. Another mechanism is the downregulation of cells from dying, particularly in control of a particular receptor called FAS, and that is the way immunoglobulin works in one very particularly dangerous disease called toxic epidermal necrolysis. There are also these interactions between the specific parts of the antibody called idiotypic networks that can also serve to regulate antibody function. Then you'll see in the middle, where the two squares are joined, there are some mechanisms that are shared in common. In other words, things that can affect specific pathogens but can also control immune functions. One is the neutralization of something called superantigens, and superantigens are things produced by infections that can stimulate the immune system, and therapeutic antibody preparations, polyclonal preparations, can neutralize these. And they can also neutralize something called PAMPs, or pathogen-associated molecular patterns, that lead to inflammatory responses. So some general mechanisms. One particularly illustrative way of looking at the way antibodies function is in this next video. And here what you can see is a pathogen. This is this light region in the middle of the slide that looks like a halo, and that is actually a dangerous organism. The large entity below it is a phagocytic cell. That's one of the engulfing cells of the immune system. And what you'll see as this video starts is that the phagocytic cell encounters the pathogen because the pathogen is coated with antibody. And the receptors on the surface of the phagocytic cell allow it to engulf and ingest the dangerous organism, leading to its neutralization and eradication. So let's now talk more about the therapeutic immunoglobulin preparations themselves. Let's talk about how they're made. These therapeutic immunoglobulin preparations need to come originally from people. As I mentioned earlier, we make billions and billions of different antibody specificities. In order to be able to supply an individual with potentially all of the different antibodies they will need, the preparations need to be generated from the source material, the plasma, of thousands and thousands of healthy individuals. And in fact, the United States Food and Drug Administration recommends that greater than 15,000 individuals be used to prepare a single batch of therapeutic immunoglobulin. This comes from commercial plasma collection centers where individuals go into the center and donate their plasma for this very purpose. And importantly, all products available, all therapeutic immunoglobulin products available in the United States must come from plasma that are obtained in the United States. And in the images at the bottom of this slide, you can see an individual at a plasma collection center donating plasma. And in the next image over, you can see an individual who's collecting the different plasma donations. And then finally, on the far side of the slide, you can see the collection vesicles in which the plasma is combined to generate these large pools of plasma from which polyclonal immunoglobulin can be generated. Now, what types of polyclonal immunoglobulin are available? And that's summarized in this next slide. The first type, and the main type that many of you are familiar with, is intravenous immunoglobulin, called by the FDA immunoglobulin intravenous, IgIV, but we more commonly call it IVIG, and I will refer to it as IVIG throughout this talk. A less well-known preparation and an older preparation is intramuscular immunoglobulin, or immunoglobulin intramuscular, IMIG. A more recently available preparation in the United States is subcutaneous immunoglobulin, IgSC, or I'll also refer to it as SCIG. And then there are a variety of hyperimmune immunoglobulins, and those are immunoglobulins which have high guaranteed specificity against particular dangerous entities, such as tetanus or cytomegalovirus, and I won't mention those any further. What I will do is briefly review and put this up in addition for your information about the preparations that are available currently in the United States. And on this slide, what you see are the intravenous immunoglobulin preparations currently available. They're presented in this tabular format with the product names on the one side of the slide so that you can distinguish some of the different characteristics that these products have. Some of them are available in liquid formats. Some of them are lyophilized, in other words, in a powder format that needs to be reconstituted. They each contain a stabilizer that helps the antibody molecules stay as single molecules and not clump up and aggregate. And those stabilizers are different. Some use sugars, some use amino acids. They each have different contents of immunoglobulin A, which is present in blood and is also present as part of the process in generating these preparations. They have different osmolarities, and some of these are similar to and some are different from the osmolarity of human blood. They also are available in different storage formats, some which can be stored at room temperature, some which need to be stored in the cold, and they are made by different manufacturers. Those are the intravenous products. In the next slide, there are subcutaneous and intramuscular products available in the United States. The first listed are the currently available subcutaneous products, and they have also different characteristics. Most notably, they're present in different concentrations, a 10% and a 20% immunoglobulin. There is also a singular intramuscular immunoglobulin preparation still available in the United States as well, listed at the bottom of this slide. Because many of the products are distinct and the characteristics of these products are different, one asks the question, are there right immunoglobulin products for particular patients? And there are certain considerations that one might make when considering that question, and those are outlined in the next slide. In particular, there are a number of features that make these decisions very important for small subsets of patients. In particular, and I'll run through these, the product that contains sucrose would be important to avoid in individuals that have renal risks or kidney disease. Glucose, which is contained in a product as a stabilizing agent, would be important to avoid in individuals that have diabetes because the extra sugar load could make their management of their diabetes difficult. Some products contain higher sodium than others, and these would be important to avoid in those individuals with cardiovascular risks or in infants. Similarly, some have high osmolarities, which the same warnings apply. Also, some have higher fluid loads given their lower concentration, in particular 5%. This you'd want to avoid in individuals that have free water restriction and perhaps take caution in small infants. Certain immunoglobulins use amino acids as stabilizers, and those might be of concern in individuals with certain metabolic disorders. Again, all the immunoglobulins except one preparation in particular have differing concentrations of immunoglobulin A, which might be relevant to consider in individuals that have particular sensitivities to immunoglobulin A. And in thinking about the tolerability of these different products, there really have only been 2 studies that have done head-to-head comparisons that have been of products that are currently available to products that are no longer available. So those are not really germane to our current practice, but they do tell us that there are differences in tolerability of particular products, and these differences one might then convert into the currently available products in thinking about their applicability to individual patients. So those are the issues specific to product selection. What are the indications for these products? Well, there are 7 currently U.S. Food and Drug Administration approved indications for immunoglobulin, for intravenous immunoglobulin and or subcutaneous immunoglobulin. The 7 that I'm going to list are for intravenous immunoglobulin. There is one FDA-approved indication for subcutaneous immunoglobulin, and that is primary immunodeficiency. All of the intravenous immunoglobulins are also approved for use in primary immunodeficiency. The others, at least for which some products are approved, some of the intravenous immunoglobulin are approved, include prevention of bacterial infection in individuals with B-cell chronic lymphocytic leukemia, prevention of coronary artery aneurysms in individuals with Kawasaki disease, prevention of infections and graft versus host disease after bone marrow transplantation, reduction of serious bacterial infection in HIV-infected children, to increase the platelet counts in individuals with idiopathic thrombocytopenic purpura, and to improve neuromuscular disability in chronic inflammatory demyelinating polyneuropathy. Those are the 7 FDA-approved indications. There may be more in the future, and that is something one needs to consider. However, there are well over 100 different uses of immunoglobulin described in the medical literature. And on this slide, I'll point to really what end up being probably the top 8 supported uses of IVIG, and that I mean supported by evidence. So that is primary immune deficiency, immune thrombocytopenic purpura, Guillain-Barré syndrome, chronic inflammatory demyelinating polyneuropathy, multifocal motor neuropathy, Kawasaki disease, B-cell chronic lymphocytic leukemia, and in transplantation. But again, that's just 8, and there really are quite a few more. In fact, this evidence review that we had published in 2006 described 80 different indications for immunoglobulin, and a follow-up article to this is in process now, which may even describe more. In this article, and I'd like to just serve an introduction to this article for you, which is freely available as a download from the internet. What this did is it went and it graded the evidence supporting the different uses of immunoglobulin according to that presented in this table, standard Cochrane database evidence ratings. When you look at the different indications, and here again this article looked at 80 different indications, it divided them according to specific categories. Across the top, you'll see the different indications, that is immunodeficient indications, autoimmune indications, neurological indications, infectious indications, and miscellaneous, and divided them according to the strength of evidence supporting their use, whether that was perceived as definitely beneficial, probably beneficial, maybe beneficial, and unlikely to be beneficial. And you can see how these categories played out. And in fact, there were 9 indications across all of the different indications evaluated, which were perceived as being definitely beneficial, another 15 which were probably beneficial, and 37 which may be beneficial. And that is served as an important guide in thinking about the use of immunoglobulin therapy. And what I'll do is dive a little bit deeper into this article for your review. And in breaking this down across some of the different indications, this first table, and again these are taken directly from the article and you can look back to it for reference, looks at the use of IVIG in primary and secondary immunodeficiencies. What you'll see for those that are definitely beneficial are the primary immune deficiencies with absent B cells, also such as X-linked agammaglobulinemia, the primary immune deficiencies with hypogammaglobulinemia and impaired specific antibody function, such as common variable immune deficiency, and also in the secondary immune deficiencies, prevention of symptomatic cytomegalovirus in bone marrow transplant recipients. And then this moves down to the probably beneficial indications. So primary immune deficiencies with normal gammaglobulinemia, so normal levels of IgG, and impaired specific antibody production, such as specific antibody deficiency. Here are chronic lymphocytic leukemia with reduced immunoglobulin levels and a history of infection, and the prevention of bacterial infections in HIV-infected children. In those where it may provide benefit, in the prevention of neonatal sepsis, and some where the group perceived it was unlikely to be beneficial, That is in individuals who only have IgA deficiency or only have IgG4 subclass deficiency. And I've spent a little bit more time going through that table, and I'll spend a little bit less going through the others. There are a variety of autoimmune diseases in which the group felt IVIG was highly supported by the evidence. These included Graves' ophthalmopathy and ITP, and then the others are listed for your review. In the neuroimmunological disorders, again, the top indications, Guillain-Barré syndrome, CIDP, and multifocal motor neuropathy, and those we had mentioned already, and then a large number of other indications for which immunoglobulin has been utilized in neuroimmunological disorders. I'd like to move on and talk about some of the other indications of immunoglobulin, back to the evidence review. Again, in the infectious and infection-related disorders, those that were perceived to be definitely beneficial included Kawasaki disease and the prevention of CMV disease, cytomegalovirus disease, in individuals undergoing transplantation, and there were a variety of others which were perceived to have different degrees of utility. There are a number of miscellaneous indications for which IVIG has been used, and these have ranged from wildly different disorders spanning multiple different organ systems. There were none that were perceived as definitely beneficial, but an important one that was perceived as probably beneficial, and that I mentioned earlier, which is toxic epidermal necrolysis, which represents a severe and life-threatening and previously uniformly fatal form of allergy to a particular agent. And in a landmark study that was performed 15 years ago, the investigators found that whereas these individuals, a small group of 10 patients, would usually uniformly die from this disease, that these individuals were almost uniformly saved and survived after having received immunoglobulin, and this has become a standard of care in this indication. And again, there are a variety of other conditions for which immunoglobulin has been used, and in some cases it is supported by a variety of evidence. So given that we've run through almost 80 different diagnoses, how does one consider which patients should receive immunoglobulin? And I would propose the following, especially because in the earlier slides we talked about how difficult it can be to make immunoglobulin. It really is a relatively precious resource. We have to think about how to prioritize these different uses. And in this general schema, what I would propose is we think of the efficacy of other treatments for those diseases, whether they are very poor in terms of improving the lives of patients and improving their outcome, or whether there are excellent other therapeutic options for those diseases. And then we also have to layer on top of that the severity of the disease, whether this is a fatal disease, as shown by the red up in the upper left corner, or whether this is a relatively mild disease. An example of something that would fall in the upper left corner would be this toxic epidermal necrolysis, where patients uniformly die and immediately if they receive the diagnosis, and there really are no effective other treatments. So immunoglobulin really serves an essential purpose. Also up in this left corner would be primary immune deficiency. Individuals do not make the immunoglobulin molecules, and therefore there really are not other treatments which can fill that gap. I would also propose that one could subdivide this grid to create a schematic essentially for how these different indications should be viewed. And as we get involved over time with potentially conserving healthcare resources, I think it is important to think about the different indications for immunoglobulin in this regard. Aside from thinking about the evidence-supported uses of immunoglobulin, we also have to think about the appropriate use within individual indications. And I'll highlight that for you on this particular slide. We have to think about the accurate definition of the individual indications. We have to consider individual guidelines for usage within the given indications, and we have to collaborate as healthcare providers with insurers and with government to generate rational and effective criteria for which the provision of immunoglobulin can be considered. So I'd now like to move into the indication which I personally focus on most, which is primary immune deficiency, and would like to get into a case presentation. This case involves a 12-month-old with recurrent ear infections, otitis, and upper respiratory tract infections. And here he is depicted on this next slide. He had his first ear infection at 6 months of age. He had 5 episodes since that time, and his mother claimed that he is always getting sick. He had seen his pediatrician on numerous occasions and been prescribed antibiotics and responded well to those antibiotics. Eventually, after this pattern continued, immunoglobulin studies were obtained, and he was found to have an IgG level of 72, an IgM of 12, and an IgA that was undetectable. He had also received his normal pediatric immunizations and was found to have a tetanus titer of 0.3, a diphtheria titer of less than 0.01, and no protective pneumococcal titers of those measured. For that reason, he did not generate antibody responses. So this diagnosis of almost undetectable immunoglobulin and the inability to generate any antibody specificity is consistent with agammaglobulinemia. Agammaglobulinemia is where the B cells, the factories of antibody, fail to differentiate because of genetic defects, and at least the lack of B cells is depicted here in this slide. This individual, as you can see on the right, in these 2 green flow cytometry diagrams, has nothing in this upper left quadrant. In that upper left quadrant, as you will see in the normal individual shown on the left, has this collection of green dots. Those are what represent the B cells. This child had no B cells, no factories of immunoglobulin. And in the majority, that's due to an X-linked disease, again called X-linked agammaglobulinemia, that's due to the deficiency of a protein called Bruton's tyrosine kinase. And that is shown in the 2 diagrams on the right. And in the patient's cells, it would look similar to this diagram, that there is no peak off to the right because there is no Bruton's tyrosine kinase contained in their cells, and these are evaluated in platelets, which also express this protein. The mother of this patient, because this is an X-linked disease, is a carrier and therefore has 2 peaks. Some of her platelets have no Bruton's tyrosine kinase, and some of her platelets do have it. In the scenario, a normal scenario, which is not shown here, there would be 1 peak and it would only be off to the right, where all of the cells would have Bruton's tyrosine kinase. Why is it called Bruton's tyrosine kinase? Well, it's named after the individual shown in this slide, Bruton. Bruton described this disease over 60 years ago. And here is an element shown from his original paper. And that was done in collaboration with the other individual shown on this slide, Tiselius. Tiselius invented a machine that was first used for mechanical separation of the proteins in serum. And that's what these diagrams show here, were the output from Tiselius's machine. And what Tiselius was doing was obtaining pediatric values for the proteins in serum. And Bruton had a patient, as shown in this figure in the middle, where there was no gamma globulin peak. And you can see that that peak is absent in that middle diagram. That patient, Bruton found, had recurrence of infections and became the first patient with a primary immune deficiency formally defined in the medical literature with X-linked agammaglobulinemia. What Bruton also did, as you can see in the bottom, is he provided immunoglobulin back to that patient, and you can see the gamma globulin peak on this diagram is restored, and provided the first polyclonal immunoglobulin therapy back to a patient with primary immune deficiency, and this patient did well on that therapy for many years. For the patient I discussed with you in this case study, here he is several years later, looking well and healthy and indistinguishable from any other 4-year-old boy. And this is because he was on immunoglobulin replacement, and he had great resistance to infections on that therapy. The graph here on this slide is meant to kind of highlight the progress that we've made in caring for the primary immune deficiency diseases over time. In red is the survival of patients with X-linked agammaglobulinemia in the 1950s, prior to the advent of immunoglobulin replacement therapy. And you can see that the survival was abysmal, just a few years. When immunoglobulin replacement therapy was first invented, it was largely given in smaller doses through the intramuscular routes. And here, as shown in the blue line, in the 1980s, the survival of patients with X-linked agammaglobulinemia was improved from the 1950s, but still suboptimal. And this graph represents the low-dose provision of immunoglobulin therapy, as well as the use of the better use of antibiotics. But you can still see in this graph that 20% of the patients had passed away within their 20s to 30s. Now you compare this line to the current, which is the black line, and this is registry data from 2006, showing greatly improved survival over time. And this is something that one would correlate from improved medical care, but also the advent of intravenous immunoglobulin therapy as routinely and hopefully optimally provided to individuals with primary immune deficiency, and in this case, X-linked agammaglobulinemia. And one thing that we really all need to think about is how to provide optimal immunoglobulin therapy to our patients, and that includes more than clearly was done in the 1980s. And this represents an ongoing area for improvement for us all, in that there are opportunities to improve and to do better, and that the provision of immunoglobulin therapy to a primary immune deficiency patient does not equal the provision of optimal therapy. And there are many different guidances for optimal therapy, and something which we all need to consider in our patients. And ultimately, it needs to come back to how the patient is doing clinically. And if the patient is not doing as well as we might like, we really need to think about how we're providing therapy to that patient and what opportunities we may have for improvement. With that said, I would like to finish discussing some overall synthesis and some guidance for practice as it applies to immunoglobulin therapy. And one of the single most important capsule summaries of this are what are referred to as the 8 guiding principles of immunoglobulin therapy, as available from the American Academy of Asthma, Allergy, and Immunology. And I would encourage you to visit the website depicted here, because these are available with detailed explanation as a free download. The document itself is called the Tenets of Antibody Replacement Therapy for Primary Immune Deficiency, and again, it is divided into 8 guiding principles, and I think it is important to review those to consider in your interactions with patients to try and achieve optimal outcomes. These are as follows. The first is indication. Immunoglobulin therapy is indicated as replacement therapy for patients with primary immunodeficiency diseases characterized by absent or deficient antibody production. And there are substantial evidence supporting that. Again, the evidence supporting these statements and a detailed description are available on the website. The second are the diagnoses themselves. There are a large number of diagnoses in primary immune deficiency for which intravenous immunoglobulin is indicated and recommended. In fact, the most recent summary of the International Union of Immunological Societies describes 154 different primary immune deficiency diseases. At least 64 of these affect antibody production. And rather than list 64 different diagnoses, it's important to consider that there are a large number of individual primary immune deficiency diagnoses in which the course can be drastically changed by the appropriate provision of immunoglobulin therapy. The third guiding principle is that of the frequency of immunoglobulin treatment. Immunoglobulin is indicated as continuous replacement therapy for primary immunodeficiency. And once a diagnosis is made and conferred, it is inappropriate to stop therapy periodically to assess whether or not the patient has the diagnosis, because once the diagnosis is conferred, that patient will have that diagnosis for life. The fourth is the dose. The dose of immunoglobulin for patients with primary immune deficiency should be considered as at a starting dose of 400 to 600 milligrams per kilogram every 3 to 4 weeks. For subcutaneous immunoglobulin, that would be that divided on a weekly basis, in other words, 100 to 200 milligrams per kilogram per week for subcutaneous immunoglobulin. According to expert guidances, it would be inappropriate to start patients at lesser doses, and that would be consistent with current literature describing the outcomes of patients and the expert opinion of dosing patients at these levels. The fifth guiding principle is that of immunoglobulin trough levels. IgG trough levels can be useful in some diagnoses to guide care, but are not useful in many diagnoses, specifically in ones where individuals might have a normal level of immunoglobulin, but might be completely deficient in the quality of immunoglobulin, and there checking trough levels may not be very useful. Importantly, it should not be a consideration in access to immunoglobulin therapy. What is important there is the diagnosis and the clinical status of the patient. The sixth guiding principle is that of the site of care. The decision to infuse immunoglobulin in a hospital outpatient or community office or home-based setting really needs to be based upon the clinical characteristics of the patient. And given the nursing audience, I will cover that in a little bit greater detail in just a minute. The next is the route of immunoglobulin. The route of immunoglobulin administration must be based upon specific patient characteristics, and that particular routes are going to be more optimal for particular patients. And that finally, number 8, the product. The immunoglobulin products themselves are not interchangeable as it relates to particular patients. And we discussed earlier the particular patient characteristics that can drive that initial decision. But again, once a patient is stable on a particular immunoglobulin product, they are at greater risk for adverse reactions to that immunoglobulin when changed to other products, and that therefore these products truly are not interchangeable. I would like to comment on what we talked about was the site of care, and that also on the Quad AI website in what is called the IVIG toolkit, where you will find those 8 guiding principles, there are also site of care guidelines. There are specific criteria supporting the use of immunoglobulin in the different sites of care. These include the hospital inpatient, physician-nurse supervised infusion, the hospital outpatient setting, also supervised by physician or nurse, the physician office-based physician-nurse supervised infusion, the home-based infusion with nurse supervision, and then the home-based infusion without nurse supervision. And some specific issues relating to these, again, are the decision to infuse immunoglobulin in a hospital inpatient, hospital outpatient, community office, or home-based setting must be based upon clinical consideration. And there are 5 key points outlined in this document. The failure to base this decision upon patient experience and circumstance and choose the appropriate site of care could place a patient at risk unnecessarily. Changes in immunoglobulin product should be provided under physician supervision in a facility equipped to handle the most severe of acute medical complications. And there may be exceptions to that based upon physician and patient experience. However, this is an important rule to take under consideration. Certain patients continue to require higher levels of monitoring and intervention during immunoglobulin infusions as number 3, and that can relate to specific adverse event profiles or ongoing chronic issues relating to a particular patient. Number 4, patients who have tolerated therapy without a history of adverse events may be considered for lower levels of supervision during their infusions. And 5th, that given the options for providing immunoglobulin therapy, specific patient experiences mandate or preclude specific sites of care. And again, getting back to the fact that one really needs to consider the patient-specific experience and not approach all patients with immunoglobulin therapy generically. So in the last slide, I would like to conclude what is the best practice in immunoglobulin therapy and how to support it. Immunoglobulin therapy represents life-saving or life-altering therapy in many diagnoses of all different types, that the consistent reevaluation of data regarding the evidence underlying these indications, as well as the best practice for administering immunoglobulin therapy in these indications, is essential. And finally, always consider matching the therapy and its intricacies to the particular patient. And with that, I would thank you for your attention and wish you the very best in caring for your patients.